Good evening, everyone. It's my pleasure to introduce Dr. Muthu Sakthivel, who's Assistant Professor of Radiology, Cardiothoracic Imaging, and Co-Director of Cardiac Imaging at University of North Carolina, Chapel Hill. And he has done his fellowship in the same place. He gave a few topics that he could talk on. So I thought this would be a nice topic to say when we should suspect vasculitis, when we should give this in our reports, when should we say to do vasculitis workup and such things.
Good evening, everyone. Today we are going to discuss about imaging of pulmonary vasculitis and specifically when to blame the vessel. So this is the hospital where I work, University of North Carolina, Chapel Hill. This is where all the magic happens. So my objectives for this lecture is to discuss the various inflammatory conditions that affects the pulmonary vasculature, to reiterate the fact that pulmonary vasculitis is indeed a multidisciplinary diagnosis, not just the diagnosis by imaging alone, and to discuss about the role of radiologist in determining the diagnosis and prognosis of vasculitis. And also we will end up, and finally we will end up forming a diagnostic algorithm so that we can make a specific diagnosis of what types of vasculitis is affecting this patient. Why we need to pin down a specific diagnosis? First of all, we need to treat the patient. That's the paramount importance. A diagnosis of pulmonary vasculitis carries a very strong predilection of how the treatment is going to pan out. If you're suspecting infectious vasculitis, it's going to pan out as either antibiotics, and if the patient is having complications or like any of the aneurysm or anything associated with infectious vasculitis, it's going to go to surgical intervention. When you suspect inflammatory vasculitis, the treatment is going to be steroids. So it is very important. We need to make a precise diagnosis which will guide the precise therapy. Histopathology. There are three basic patterns which will parallel the imaging appearance. The acute injury to the vessel, which results in vessel wall abnormalities like vessel wall thickening, vessel wall enhancement, and perivascular inflammatory changes, and then alveolar filling, which may be in the form of tiny central lobular nodules, which may correlate with either hemorrhage or like central lobular mass-like opacities. Otherwise, it can go as either nodules. So this is how the stage of inflammation goes, and that parallels the imaging also. Starts with the vessel, going into the alveoli and going into the nodules. It's very important to not forget the airways, which are always traveling along the blood vessels. So in many cases, I have seen people are more focused on vascular findings, but they totally miss the pulmonary findings. And now by pulmonary findings, I mean not only the segmental airways like consolidation and all those stuff, but the larger airways like trachea also needs to be seen. The important thing about pulmonary vasculitis is it affects intima, media, and adventitia, all three layers together. But the most important thing apart from this, it need not to be circumferential all the time. It can be localized within a single vessel, even with inflammatory vasculitis. This criteria is allowed. It's not that only in infectious vasculitis you get focal, but in inflammatory also you can get focal. There are different types of inflammation, starting with acute inflammatory phase. This is where the patient present with the prodrome of illness. They will have raised ESR. Once they go into the phase of chronic necrotizing granulomatosis phase, the patient will be having aneurysm, stenosis, or pseudoaneurysms. So American College of Rheumatology is all about vasculitis. They characterize the vasculitis based on the size of the blood vessel. The large vessel vasculitis includes Takayasu and giant cell. The medium vessel vasculitis includes polyarteritis nodosa and Kawasaki. And the small vessel vasculitis includes polyangitis, GPA, and Chokes-Strauss. The thing about the other type of vasculitis is based on how the etiology is, how the etiological origin is, like cryoglobinemic vasculitis, IgA vasculitis, urticarial vasculitis. But we don't need to worry about these things in pulmonary because these things never affect the lung parenchyma. We are going to discuss about the pulmonary renal syndrome, which will manifest as anti-GM as well. The 2012 Chapel Hill consensus is the one which resulted in the classification of the blood vessels based on the size. There is a systemic disease or associated etiology classification that includes autoimmune, sarcoid, our famous APLA, antiphospholipid, drug-induced, paraneoplastic, and infection. Vessel size is the main criteria in classifying the vasculitis, and as like every other classification, this classification also keeps on evolving. I think every 10 years, a bunch of people gather together and make some changes so that they can keep their job. I think that's what all this classification is about. They just keep on redefining it. The size of the vessels, based on that, large and small, the medium vessel vasculitis involving PA and Kawasaki, it rarely causes pulmonary involvement. Kawasaki can cause coronary involvement, of course, whereas actual pulmonary involvement is extremely rare in these two occasions. So we are not going to discuss about this. We are going to focus on the large vessel vasculitis and small vessel vasculitis, and we are going to discuss about diffuse alveolar hemorrhage. What is the role of radiology? The most important thing is imaging findings added by proper clinical history and laboratory data is the pivotal thing for diagnosis of vasculitis. Why more follow-up imaging is performed? Because a negative ESR doesn't mean that the patient cannot have the findings of vasculitis, because vasculitis evolves in phases: pro-inflammatory phase, inflammatory phase, and fibrotic. Once the patient goes into fibrotic phase, the ESR would not necessarily need to be positive. So follow-up imaging is very important when you diagnose a patient with trachea. So you need to make sure down the line, at least a year, you have to image. The role of radiology: CT is used for structural abnormalities, and MRI is used for functional abnormalities and perivascular tissue assessment, and PET-CT is to assess whether the disease is metabolically active. For example, this is a patient with giant cell arteritis. You can clearly see the branch vessels from the aorta. There is perivascular thickening in this T1 black blood images, and this is the same patient who underwent PET-CT. You can clearly see with the FDG PET, the activity along the aorta as well as the branch vessels are increased, indicating the patient is having acute active vasculitis. What else the imaging can offer? Complications of vasculitis like stenosis, pseudoaneurysm. It can guide tissue sampling if someone really wants to biopsy, because most of the time imaging is all enough to make a diagnosis, but people who wants to take a biopsy, they will go based on where the disease is active, and it also useful for detecting the disease flare up. When to suspect a pulmonary vasculitis? The first thing is atypical symptom in an atypical age patient, and presenting with the patient if has a history of rapidly progressive glomerulonephritis, along with pulselessness, ulcerating upper airway lesions, along with if the patient present with upper airway lesions and dyspnea, pulmonary renal syndrome, rapidly proliferating glomerulonephritis, and the patient presents with dyspnea, then you have to think of peripheral neuropathy in a 12-year-old kid. Immediately you have to jump the gun. Palpable purpura in a young kid. You need to think of vasculitis. Vasculitis is far more common than what we are thinking, because many patients, it will be subtle and it will never be diagnosed. All we end up is having a chronic fibrotic phase, stenosis or pseudoaneurysm. Then they will start working it backwards. Then the patient will come up with all these complaints they had in the past. It is very important to have a detailed history to produce a proper vasculitis diagnosis. Pulmonary vasculitis, for practical purposes, the usual suspects in the place I work, it's a cancer hospital, so predominantly I get to see infection, and then drug related. The young people who are in college going kids, they mix multiple drugs, they snort it, and they end up having pulmonary alveolar hemorrhage. And toxic inhalational injury can also result in pulmonary hemorrhage. Whereas inflammatory vasculitis, it is classified as large vessel vasculitis and ANCA-associated vasculitis. And we are going to discuss about the systemic vasculitis, which will turn with pulmonary renal syndrome, which presents as diffuse alveolar hemorrhage. So for all these practical purposes, when you look at a CT, the first thing is to rule out whether I can see any evidence of infection within the image. Is there any indwelling catheter which can trigger a response, inflammatory response across the vessel wall? The second thing is to look for the clinical history and upper airway lesions. And if nothing is there, and then you are seeing a patient with hemoptysis and full-blown ground glass opacity, then you can think of pulmonary renal syndrome. Approach to pulmonary vasculitis, age of the patient is the paramount importance, laboratory and serological data, imaging findings, and which vessel is involved. That is also paramount. You cannot be calling GPA in a patient who is having arteritis. You cannot be calling Takayasu just because there is a tiny segmental vessel is inflamed. So you need to be very specific which vessel is involved, and we have to look at the histopathological features as well. So as we go into the imaging findings, we have a myriad of imaging findings which are very non-specific. But if you put the clinical and laboratory data on top of everything, we can make the diagnosis. And we are going to see how I make a diagnosis by looking at a case, by going through a different set of cases. First and foremost, to begin with, the pulmonary parenchyma, the common findings are consolidation, ground glass, nodules, and mass lesions. All these things are due to parenchymal hemorrhage. And airway abnormalities can occur. As I already told you, that you should always look for airway abnormalities in trachea and small airways disease. And then vascular findings, vessel wall thickening, vessel wall enhancement, perivascular tissue stranding, stenosis, aneurysm, and pseudoaneurysm. These are the findings you will see in vasculitis, nothing else. But these things stand alone, we can't make anything specific. Along with clinical data, we can make it very specific. So case one, let me start. Give me a few minutes, it is getting loaded. So this is a 25-year-old female presented to the emergency department with pulselessness, and she had like a prodrome of illness, and she had hemoptysis as well. So the concerned ED doctor, as usual for every other patient, they ordered a PE study, and our technique was timed at pulmonary arterial enhancement, and that's the reason the aortic enhancement is not. This is not an actual CT done for aortic, but still it lets us make some diagnosis. So as we go down further, the first thing which jumps at you at the level of the aortic arch branches, you can clearly see there is distinct vessel wall enhancement, which is centered along the branches of the aortic arch. And as you come down, the aortic arch is also thickened. And then the thickening is extending into the ascending thoracic aorta. By this time, in a 25-year-old female with raised ESR and pulseless, we are certain what we are dealing with. This is a patient of Takayasu arteritis. But the most difficult diagnosis is always the most difficult finding is always the second finding, not the first one. First one jumps at you. What is the second thing which jumps at you in this case? As you know, since it is done for a PE study, you can look at the pulmonary artery. The pulmonary artery is definitely increased in size. 3.9 centimeter, which is extremely larger for a patient of this age. And the whenever I look for pulmonary arterial enlargement, I always measure the aorta as well. If the aorto-pulmonary ratio, the pulmonary and aortic ratio is greater than 1, then I would lean towards enlarged pulmonary artery and pulmonary hypertension. But this patient is too young to have pulmonary hypertension, but the pulmonary artery is enlarged. So we are going to go and look at it, what is going to happen. And as we scroll down further, you can see the right atrium is enlarged, the right ventricle is enlarged, all the way to the down. Then that doesn't make sense. If the pulmonary hypertension is due to valvular stenosis in a young kid, you shouldn't be seeing you should be seeing right ventricular hypertrophy. Here, that is what we are seeing here is there is a right ventricular hypertrophy, but there is no valvular abnormalities. But the pulmonary artery, main pulmonary artery, and the bilateral proximal pulmonary artery looks a little bit plumb. And as we go down further, you can see there is a area of narrowing within the distal right main pulmonary artery, as well as within the distal left main pulmonary artery. And as we go down further and further, you can see there is more of soft tissue infiltration, and there is a tiny thrombus within the pulmonary artery as well. Then coming into the lung parenchyma, what we are seeing here is mass-like consolidation surrounded by ground glass opacities all around. And also in the lingula, left upper lobe, and in the right upper lobe with smooth interlobular septal thickening. So what are all the findings we are having? We are having vessel wall thickening, vessel wall narrowing, vessel wall thickening, and there is enlarged main pulmonary artery, and there is stricture/narrowing of the bilateral main pulmonary arteries. And then as we come down further in the lung parenchyma, what we have is mass-like consolidation with surrounding ground glass and interlobular septal thickening. When you see mass-like consolidation with surrounding ground glass in a patient you are suspecting vasculitis, the immediate thing to jump for is a pulmonary alveolar hemorrhage. So this is a rare, usually Takayasu arteritis, the involvement of pulmonary arteries is less than 50%. But in this patient, we have the pulmonary arterial involvement, and also it extends into the pulmonary parenchyma as well, and that resulted in diffuse alveolar hemorrhage. The same patient underwent a PET CT. Give me a few minutes. It's kind of moving. This is the raw images of the PET CT. Right off the bat, you can clearly see there is some faint activity along the ascending thoracic aorta. Let me, once it loads, I can show you the actual recon. So here is the volume rendering along with the PET CT reconstruction. You can clearly see there is inflammation along the ascending thoracic aorta, descending thoracic aorta, and some inflammation along the pulmonary artery areas where we saw narrowing. So this is a case of 25-year-old female with Takayasu arteritis. Oh, large vessel vasculitis, we have giant cell arteritis and Takayasu. The Behçet's disease, we can ask it for medium vessel as well as the large vessel as well. The vessels involved are aorta and its main stem branches. The direct signs of vascular disease can be seen on imaging. There's classic triphasic pattern. Only in a minority of cases you will see that, but most of them, they will have a mixed phase. They will have a pre-pulseless phase, vascular inflammatory phase, and fibrotic occlusive phase. This is the phase most of the patients present with the fibrosis and occlusive, because patients have stenosis and they may have vascular aneurysms, and they will see like palpable aneurysms on their extremities. That's where they will present is various phases can coexist at the same time. And this is exactly the reason why you need to have a surveillance imaging for Takayama arteritis. That is vessel walls, as we discussed, that is vessel wall thickening and enhancement, stenosis, occlusion, and aneurysm. When this develops, these patients will have signs of ischemia like claudication pain. And the location commonly involved are thoracic aorta and left subclavian. For people who are preparing for competitive exams, always remember left subclavian artery is the most commonly involved artery in Takayama arteritis. Pulmonary involvement is less common, but in our patient, we had extensive pulmonary involvement in the form of focal structural narrowing, as well as the diffuse alveolar hemorrhage. In order for accurate assessment, MRI might be far better, because these patients can develop pulmonary hypertension and end up in right heart failure. At that time, volume assessment is of paramount importance. So you can do an MRI as well. So the case number 2. So this is a 85-year-old female presented with non-specific neck pain. So they did a CTA neck because the patient is having a headache in the temporal region, and also she has raised inflammatory markers. And then the neuroradiologist wanted me to review the uppermost part of the neck. When I looked at it, the first thing which jumped at me is the patient is, first of all, the patient is 80 years old, and there is associated presence of calcification, and then there is perivascular thickening in the descending thoracic aorta. It is not circumferential as we see on Takayasu, but it is more specific to descending thoracic aorta and also along the subclavian branches on the left side. And then as I went further, and I asked them whether there is any carotid narrowing. So they showed me the recons they did, and you can clearly see this is a patient, there is a carotid narrowing along the left side. So this patient, 80-year-old female with headache, non-specific symptoms, and then they suspected temporal arteritis. They did a CTA neck going all the way down to the aortic, just 2 centimeters distal to the aortic arch. So whenever you are protocoling a patient suspecting of giant cell arteritis, please include the upper chest at least until the 2 centimeters distal to the aortic arch, because descending thoracic aorta and left subclavian can be commonly involved in giant cell arteritis. If you just stop at the level of top of aortic arch like you do in cardiac imaging, you will lose it. So you have to go a little bit further, then only you can assess the descending thoracic aorta. So 80-year-old female with carotid narrowing and thickening along the subclavian artery and also along the descending thoracic aorta. This is a patient with giant cell arteritis. So giant cell arteritis, also known as temporal arteritis, is a chronic systemic large/medium-sized vasculitis exclusively seen in individuals greater than 50 years. Extracranial is important because most commonly it is mistaken for atherosclerotic disease. The late phase, it is more prone for thoracic aortic aneurysm and dissection. The imaging clues is, first and foremost, even if you don't have the age, if you see a calcified plaque with surrounding thick rind of atherosclerosis, always suspect giant cell arteritis, because it is difficult for a 20-year-old peri-inflammatory to induct a calcification even after 25 years of illness. So then you see an 80-year-old with presence of calcification and surrounding perivascular thickening, always think of giant cell arteritis. If you don't have the age, look for presence of calcification. If there is calcification, sure, the patient might be older in age. Look for any other signs of atherosclerosis. If you don't have any clue, just go and ask the tech, what is the age of the patient? Look at it. And then what we have is concentric aortic thickening, periaortic inflammation, aortic aneurysm, classically in ascending aorta, and there is presence of aortic dissection, stenosis, and aneurysms are common presentation. It differs from Takayasu just by the age of patient and also presence of calcified atherosclerotic plaques everywhere else in the body. So as we differ from the Takayasu and giant cell, Takayasu is preferably in the younger population, 30 years. It is giant cell is more on 50 years of age. Aorta and major branches are affected in Takayasu and it spares the cranial arteries, whereas in giant cell, aortic arch, branch vessels, and cranial arteries is involved, as in our case. There will be segmental involvement in Takayasu, whereas giant cell, wherever there is concomitant atherosclerotic disease, you can see some inflammation. Takayasu can present with vascular inflammatory and late occlusive phase, whereas giant cell asymptomatic until the occlusive phase begins. Again, the major discriminator is age of the patient. The role of PET-CT in large vessel vasculitis. FDG uptake is an indicator of inflammatory activity. It is useful for follow-up of vasculitis after the treatment. The patient is treated with steroids. The next one is, this is a 35-year-old female presented to the emergency department with hemoptysis. Right off the bat, you can clearly see there are scattered areas of air space disease in bilateral lung parenchyma, but more predominantly on the right lung, centered around the perihilar and infrahilar region. There is a mass-like opacity with there is a central lucency within the mass-like opacity. At this stage, the differentials are very broad. You can still think of infection. You can still think of tuberculosis, because hemoptysis can be due to pulmonary hemorrhage as well as due to bronchial hypertrophy, and then that is leaking. So your diagnosis based on chest X-ray is limited, but you have a working diagnosis of infection versus inflammation. And then we are got the CT. On CT, what do we have is diffusely scattered on mediastinal window. We can clearly see there is diffusely scattered multifocal mass-like consolidation, which was paralleling the chest radiograph finding, which we see. And on lung window, you can see most of the mass lesions are ill-defined. So the important thing when we look for findings in CT chest is most of the findings which are ill-defined implies there is incomplete filling of alveolar spaces. In this patient, there is incomplete filling of alveolar spaces by the hemorrhage, and that is the reason the periphery of the opacities are having ground glass and the center is consolidated. And then as we go down further, you can see peripherally placed mass-like consolidation with surrounding ground glass halo. You can call this as a halo sign, but we cannot call it as fungal pneumonia because it is not in the appropriate setting. And you can see there is a cavitation. When you see multifocal cavitary and non-cavitary nodules or mass-like consolidation in a patient presenting with hemoptysis, always think about GPA, granulomatosis with polyangitis, previously called as Wegener's syndrome. So it's also previously known as Wegener's granulomatosis. It is a most common classic triad is upper airways disease, lower respiratory involvement, and glomerulonephritis. It is one of the histological hallmarks. This is limited to medium vessels to capillaries, and that is primarily the reason why it is presenting as diffuse pulmonary mass-like consolidation with surrounding areas of hemorrhage. And there are areas of necrosis, and there will be necrotizing and non-necrotizing inflammation within the GPA. And while the findings are widely variable, but the presence of cavitary and non-cavitary nodules or masses and presence of ground glass opacities, consolidation with ground glass halo, when you check on these kind of findings, you have to tick it off as granulomatosis and polyangitis. GPA can have airway involvement, as I already emphasized multiple times. Always look at the central airways. Look at this trachea. As you come down here, there is a smooth narrowing at the level of trachea. The narrowing of trachea can be very symptomatic. The reason is, with small airways disease, in order for the patient to present with dyspnea or any other forms of breathing difficulty, you need to have enormous amount of area that needs to be destructed for a patient to be symptomatic. Whereas diseases involving trachea, even the slightest of involvement can produce a significant amount of breathing difficulty in patients. And for this patient, the patient just had airway involvement of GPA. She never had pulmonary hemorrhage, but the present, when I looked at it, I saw like there is an airway thickening. And then when we worked her up, we found out the patient is having GPA. Sorry, let's go to the other one. So this is a 45-year-old male presented to the emergency department with history of fever and non-specific dyspnea. As we scroll down on this patient, we were able to see there is peripherally placed mass-like consolidation predominantly in the bilateral lower lobes. This is a very non-specific finding. Mass-like consolidation in the peripheral lung parenchyma. We can think of organizing pneumonia. We can think of aspiration pneumonia. We can think of pulmonary vasculitis. So when we have these three findings, there isn't anything we can make out of CT. There is just mass-like consolidation. But at the same time, the patient had a coronary CT a few months back. When I went back and looked at it, this was done at an outside hospital. So when we looked at the coronary CT, it was reported as the patient did not have any evidence of coronary artery disease. So as we scroll down, the one thing became apparent to me was the abrupt caliber change of the LAD, which is traveling in the atrioventricular groove. And then it came back to normal size. Look at here, this LAD, this segment, the proximal LAD, as we go down further, it suddenly increases in size and then decreases in size. So I did a 3D, I asked our 3D lab to do a 3D volume rendering. You can clearly see this is the proximal size of the LAD. This is the distal size of the LAD. The in between the LAD, that is uniform increase in size. So this makes sense. This patient is having coronary involvement and there is presence of mass-like consolidation on the chest CT. This totally implies that this patient is having EG-GPA. The patient had a history of asthma. So most of the time, Chuck straws are called as eosinophilic GPA. The patients will have a prodrome of asthma, and there will be repeated episodes of mass-like consolidation coming and going, waxing and waning over multiple priors, and there will be cardiac involvement. Cardiac involvement is the thing, the point which makes the difference between GPA and eGPA and the presence of eosinophilia in any format in the form of asthma or any other findings suggestive of eosinophilia. So eGPA, also known as Churg-Strauss syndrome. These patients have a classic triad of asthma, hypereosinophilia, and necrotizing vasculitis. Lung is most commonly involved. In heart, which is the primary target organ, the patient can have myocarditis. Coronary arteritis is the most common cause of mortality. And these patients, because of repeated inflammation, they can develop focal stenosis and focal aneurysm, as we saw in our case. Transient or fleeting peripheral consolidation and ground glass opacities over multiple prior studies, and the presence of cardiomegaly and signs of pulmonary, because this patient is predominant, this disease, there is predominant heart involvement. Most of the patients will have heart failure, and they can have pulmonary edema, and they can also have coronary aneurysms. So the difference between GPA and eGPA, the patient's age is variable in GPA, whereas in eGPA, there will be a history of adult onset asthma and allergic rhinitis, and there will be more renal and sinus disease in GPA and more cardiac involvement in eGPA. GPA will have C-ANCA positivity and eGPA will have P-ANCA positivity. Again, I'm reiterating the fact this is a multidisciplinary diagnosis. You need to have this much clinical information to make an appropriate diagnosis. You cannot just rely on imaging. If you just rely on imaging, what will you give the differentials for that peripheral fleeting consolidation of the eosinophilic pneumonia, organizing pneumonia, aspiration pneumonia, and eGPA. So in order to be very specific, we need to have clinical information. Thanks. This is a 49-year-old male presented to the emergency department with chronic history of recurrent pneumonia. So this is a chest radiograph. What we can see is the patient is having mass-like consolidation all around. At the same time, the initial workup revealed that the patient is having low hemoglobin and low hematocrit values as well. So this multifocal ground glass, multifocal hazy airspace disease with some patchy consolidation is very non-specific. The differentials includes pneumonia. If the patient is intubated, I would call it as acute lung injury as well. So the patient subsequently underwent chest CT. So as we scroll down the chest CT, it is very apparent from the CT that the patient is having an polylobular arcade of consolidation with surrounding hazy ground glass opacities. In this 45-year-old patient with low hemoglobin and hematocrit with repeated episodes of pneumonia, which was called as pneumonia. I went through the other charts and that was not pneumonia, that was the vasculitis as well. So when I scroll through it and there is some ground glass and there is mass-like consolidation, there is septal thickening, there is low hemoglobin, low hematocrit. And when we went back and asked the patient, she had occasional bouts of hemoptysis when she is doing trekking or hiking. So this implies that the patient has repeated episodes of hemorrhage, and this is indeed a diffuse alveolar hemorrhage. And when we checked at her renal profile was also altered, and the patient has had a history of chronic recurrent kidney infections as per the chart. So when we went and did an ultrasound, we found that the renal echogenicity also increased. So all of this combined together, this is a case of pulmonary renal syndrome. And the common pulmonary renal syndrome we encountered in the thoracic imaging is microscopic polyangiitis. So this is a patient who had non-granulomatous vasculitis. This is the most common cause of pulmonary renal syndrome. The patients can have rapidly progressive renal manifestations and diffuse alveolar hemorrhage, and characteristic P-ANCA positivity in 80% of the patient. So pulmonary renal syndrome, as we already talked, there will be multifocal airspace disease bilaterally in a patient with increased renal echogenicity on ultrasound. And on imaging, there will be multifocal ground glass opacities with or without surrounding mass-like consolidation. So this is our classic findings of pulmonary hemorrhage. And there's one more. This is a 49-year-old female presented to the emergency department with hemoptysis. The patient was not able to maintain stats, and also the patient was not able to maintain her blood pressure, and they put in a central venous catheter, and the patient also had had renal failure, so they were looking for a dialysis pump. Before putting the dialysis, they wanted to do the chest radiograph, and what I saw on the chest radiograph is ill-defined hazy opacities. When you have ill-defined hazy opacities in a patient with hemoptysis, always have, even if it is very faint, have that in the back of your mind. Pulmonary alveolar hemorrhage should always be in your back of mind, because hemoptysis, oh, the patient has scanty hemoptysis. It doesn't matter. Pulmonary hemorrhage, pulmonary vasculitis can occur focally. Pulmonary vasculitis can occur floridly. So whatever it is, if there is a history of hemoptysis, always retort to doing a chest CT. This patient underwent a chest CT, and you can clearly see the patient has mild diffuse bronchial wall thickening. There is hazy ground glass opacity, which is ill-defined, and also there is tiny central lobular nodules. So what these tiny central lobular nodules, these are the alveolar filling, which if you cut the patient in cross-section in a histology slide, what will you see is alveolar filled with clumps of blood, as well as the surrounding parenchyma with blood. So these tiny nodules of consolidation are equivalent to blood within the alveoli, and the surrounding hazy ground glass corresponds to blood within the lung parenchyma. So hemoptysis plus drop in hemoglobin and hematocrit with diffuse alveolar hemorrhage. Hemoptysis may be, sometimes hemoptysis may be lacking as well. Patient can have a full-blown hemorrhage, but still they may not be having hemoptysis. So the imaging clues are multifocal ground glass opacities with or without surrounding mass-like consolidation, smooth interlobular septal thickening, and central lobular ground glass opacities. Crazy paving may or may not be there. I want to talk about crazy paving with a case, because that's one of the diagnosis which is one of the finding which is commonly misunderstood. This is a patient who is a biopsy-proven case of pulmonary alveolar proteinosis. Many places I have seen, when they say crazy paving, they always say that this is nothing but ground glass opacities superimposed with interlobular septal thickening. Trust me, it is not the case. In crazy paving, apart from having ground glass opacities and interlobular septal thickening, you need to have intralobular lines. We call it as a bird's feet appearance. If you look at this patient, you can see there is a smooth interlobular septal thickening, and also within the solitary pulmonary lobule, there is additional area of a feet-like appearance. This is when you call crazy paving. Please do not, I have seen it in many conferences, case conferences, people talking that crazy paving is equal to ground glass opacities superimposed on interlobular septal thickening. That is not, please do not spread it. Always look for intralobular lines like here. There is a smooth interlobular septal thickening, and there is an intralobular line. Smooth interlobular septal thickening and intralobular lines. So please be very cognizant when you call crazy paving. I just want to show that one more case. I have some Behçet. So this is a patient, 49-year-old male of Middle Eastern descent, who had a history of recurrent PE and questionable aneurysms on chest CTs that was done in Turkey. The patient recently immigrated to the United States, and he presented to the ER with severe dyspnea and hemoptysis. As we scroll down further, what we are seeing here is there are some cavitary nodules. What we saw is a cavitary nodules, and also there is a contrast outpouching extending from the main pulmonary left pulmonary artery, and there is surrounding soft tissue. And then as we scroll down further, you can see there are scattered ground glass opacities and some peripheral areas of linear atelectasis / scarring. I think these are because of the patient who have history of recurrent PE. I think these are all are resolved pulmonary infarct, and we can see there is an aneurysm arising from the left pulmonary artery. When you have a patient who's of Middle Eastern descent and you are having a history of recurrent pulmonary embolism and multiple aneurysms in the pulmonary arteries, always make this diagnosis of Behçet disease. It is also called as vascular Behçet or a huge Stoughton syndrome. When they call it as huge Stoughton syndrome is if the findings are just limited to the pulmonary vasculature and it is not going and involving the aortic parenchyma, they call it as huge Stoughton's. But many times the patients can have both aorta and pulmonary aneurysm. But the classic case is recurrent pulmonary embolism with multiple aneurysms of the pulmonary artery. So diffuse alveolar hemorrhage, the differentials includes with pathological capillarities and without pathological capillarities. Those with capillarities, we have ANCA, small vessel vasculitis, good pastures, and SLE combined. Without capillarities, they have mitral stenosis, drug-related, and bone marrow transplant-related. So finally, the take-home points. We are reiterating the fact that pulmonary vasculitis is a multidisciplinary diagnosis. Age of the patient, laboratory and serological data, imaging findings, and histopathological features all combined together will give you a precise diagnosis, and we can guide the patient with precise treatment. Takayasu and giant cell arteritis can share imaging findings and distribution. Age is the main important discriminator. If you see in a 25-year-old male with a history of upper extremity claudication, and there is presence of valve thickening in the aortic arch branches or the ascending or descending thoracic aorta, always think of Takayasu. If there is a patient who has history of headache, raised inflammatory markers, and also there is some claudication pain, then you have to think of giant cell arteritis. The most common group of vasculitis that affects the lungs are ANCA positive small vessel vasculitis that includes GPA, eGPA, and microscopic polyangitis. GPA is the most common small vessel vasculitis that affects the lung. The findings are widely variable. If you see multifocal cavitary and non-cavitary nodules, mass-like consolidation with ground glass halo, always think of pulmonary vasculitis. And diffuse alveolar hemorrhage is a common manifestation of pulmonary vasculitis. Both it can present primary and secondary to it. When you see ill-defined ground glass, ill-defined central lobular nodules admixed with ill-defined mass-like consolidation, always have diffuse alveolar hemorrhage in the back of your mind. Do not miss it. If you miss it, hell will break loose. So always have that in your back of your mind. Thank you. Are we on time?
Yes. Thank you very much, Dr. Muthu. That was excellent. And it was so nice that you could show all cases and made it like a case-based approach to this thing about vasculitis. I just have a few questions, and we'll ask Ms. Rituparna also whether there are any questions in the chat box. Let me ask my questions first. One is differentiating vasculitis from atherosclerosis, like for example, in the giant cell vasculitis, there were a lot of calcifications and atherosclerosis also. So we do face this problem sometimes, differentiating whether it's just atherosclerotic versus vasculitis versus another problem that we face is periaortitis, like in, say, IgG4 disease, where there is a lot of soft tissue around the aorta. So that is one thing that I want to ask you. Maybe after you answer that, I'll ask you the other questions, whether you have what do you say about this differentiating the large vessel vasculitis from atherosclerosis? Because as you know, in India, we get even younger patients like 40, 50 years, we have a lot of atherosclerosis in the younger age group also. So it's quite difficult when there are a lot of calcified plaques. And we know that even the Takayasus, after some time, they can show calcifications. So it's very difficult sometimes to differentiate. Any comments you have on that?
So to start with Takayasu and Jain cell, let me tell it from my perspective. The advantage for me is I have complete electronic medical records. I can go and look up the patient who had a scan in 2000. So my case is entirely different. For when it comes from the practice in India, the problem is we don't have that much amount of clinical data. We have to make a decision with the image which is just in front of our screen. So the first thing I look for is whether there is, most of the time it will be done at angio, whether there is any endoluminal plaques, whether I am seeing plaques within the lumen, whether there is an area of, usually atherosclerosis will be scattered everywhere. Whereas whereas in Jain cell arteritis, if you look at it, there will be like there will be inflammation external to the vessel rather than into the endoluminal part. And happens in Takayasu. So in Jain cell, age is the paramount criteria I use. I don't most of the time by talking to the rheumatologist, they always say I don't accept the diagnosis of Jain cell in 50 years old. I always want it to be patients about 60 or 70. There are a lot of variation when I speak to the College of Rheumatology people, but it's a difficult diagnosis to make. When we are in a diagnostic conundrum, the first thing is look for any presence of endoluminal plaques. If you look for endoluminal plaques, yes, there is atherosclerosis all around. It's not just going to affect the major arteries. It's going to affect the coronaries as well. Look for any presence of coronary calcifications. Then I will say, okay, this is atherosclerosis. And then if there is no any signs, the patient is presenting acutely with severe pain and there is history of headache, and we all know that ESR is the only thing most of the time clinicians use to suggest inflammation, which is basically useless. It is elevated in every other patient. So what we can do is presence or absence of endoluminal plaques, and if the patient is relatively young, I go into Takayasu. Presence or absence of endoluminal plaques, and also there is presence of calcifications, and there is perivascular thickening, I go into Jain cell. IgG4 is a very difficult diagnosis to make, and we need to have clinical data, look at the patient who has any evidence of IgG4 disease within the lung parenchyma. Jain cell arteritis usually do not may produce any changes within the lung parenchyma. Only in IgG4 we can look at the lung parenchymal changes. And also Takayasu, the lung parenchymal change we expect to see is pulmonary hemorrhage, whereas in IgG4 there is a lot of findings varying from just mass-like consolidation. The patient may or may not have hemorrhage. So IgG4 versus this vasculitis is a difficult diagnosis, but Takayasu, GCA, and IgG4 we can make it by the presence of or absence of endoluminal plaques. That's how I use the diagnostic criteria.
Thank you for that. One more question about the disease activity. I think somebody else has also asked in chat box. You mentioned about PET. Do you do MRA and like vessel wall imaging on MR?
Yes, we do MRA and vessel wall imaging, but most of the time it is going to IR. I sometimes get involved when if the patient has cardiac imaging as well, I will just report everything. So vessel wall imaging in MR is amazing. MR gives you, I think I had an MR. I'm sorry, I didn't show that. I have a case with the MR. So what I see is if you put at the black blood sequence itself, we can clearly see there is evidence of perivascular thickening. And most of the time when I use MR, I am looking for how is the periaortic soft tissue, not just the MR, not just the vessel alone. That's the one of the reason. And for PET, we use it for disease activity all the time. We don't need to ask the patient to come back for routine. We just ask them to schedule it a year. We'll ask them to have steroid treatment. We'll have 6 months. We give 6 months for the steroids to mellow down, and then we will image them.
So Dr. Jha has asked a question. I'm just going to read it out.
Sure.
Can imaging help distinguish between active inflammation and fibrosis in pulmonary vasculitis? And if so, what are the key imaging features?
The one thing I can say, based on the last 6 years work with pulmonary vasculitis, there is a lot of overlap regarding these phases. The question you are asking is active inflammation. Active inflammation, the findings are vessel wall thickening, vessel wall enhancement. Once it goes to the fibrosis, what happens is the vessel, because of repeated inflammation, it shrinks. What will you see is multifocal area of stenosis. If you cut open the blood vessel in autopsy, what you will see is there will be stellate scar-like appearance within the vessel wall, which will result to shrunken lumen. You will end, what will you have in imaging is stenosis, aneurysms, and pseudoaneurysms. So your question says whether it is acute and chronic can coexist together. Yes, and patients can have repeated bouts of exacerbation. Vessel wall thickening and vessel wall enhancement is evidence of active disease. Stenosis, pseudoaneurysm, and aneurysms are non-active disease, which is fibrosis stage.
Thank you for answering that. Another question that I have is often these people with GPA, they would be on steroids and then they may come back with some pulmonary opacities. So the big question will be, because they're already on steroids, is it like some kind of disease relapse, or is it infection? Anything that we can do in that?
My take on this is, again, going back to the clinical setting. You have this image and you're seeing multifocal cavitary lesions with surrounding ground glass. The two things which will always jump at you is whether the patient is having fungal pneumonia or whether he is having again repeated bout of vasculitis. Your clinician is your friend in that kind of cases. You have to give him a call, ask him if the patient is having high grades of fever, any other evidence of infection. Then you put the gun on fungal pneumonia. And the other important thing is if the patient is having active hemoptysis or not, and how is the hemoglobin, how is the hematocrit. And that is exactly the reason I repeatedly telling this is a diagnosis of clinical and radiological correlation. You cannot certainly call it just as vasculitis. The answer to your question is it can be both. Look at the chart, look at the hemoglobin, look at the hematocrit, talk to your clinician, then make a diagnosis.
Thank you. That was a nice thing to say, that we have to do it in combination. Yeah, like in many occasions, the lung has only that many ways to react to any kind of pathologies. Everything is ground glass, everything is consolidation, everything is nodules. So we do need a lot of clinical input before we make a diagnosis. And for those of us who are not actually having more clinical information, maybe we may have to give a wider list of differentials in case we are not able to get more clinical information, and say that we can always discuss back with more clinical information. Thank you so much, Dr. Muthu. That was an excellent talk and very, very well explained. And I'm seeing a lot of people appreciating it also on the chat. Thank you so much. Before we end, I just want to thank Ms. Rituparna and Ms. Sangeeta Bose from Clarnet for helping us out with this webinar. And also invite everyone to go to the SKI website, skirad.com, that is SCIIRAD.com. So there are some, if you become members, there are a lot of cases on the site. And we are also having our annual meeting on August 30th and September 1st in Bengaluru. So please do visit our website as well.